Hello everyone, welcome to another video. Today I'll be going over everything you need to know about the appendix before entering into the operating room. So let's discuss the function of the appendix. Why do we even have an appendix? Isn't it a useless organ? Well, the appendix is actually a specialized lymphoid organ. It's packed with immune tissue. And also, the structure allows beneficial gut microbes to form a protected biofilm. It acts as a safe house for good bacteria. So when your colon gets wiped out, like during severe diarrhea or after antibiotics, the appendix can help repopulate the gut with healthy bacteria. In fact, in 2018, a paper titled The Immunological Functions of the Appendix, an Example of Redundancy, found that patients without an appendix had worse outcomes with recurrent C. diff infections. And this is due because of the fact that they didn't have a safe reservoir for that gut biome to replenish with healthy bacteria. Now let's go ahead and move on to the appendix anatomy. The vermiform appendix, which is its anatomical name, is a blind ending outpouch of the cecum, typically measuring around 8 to 9 centimeters in length. A key surgical landmark is the tinea coli. And if you remember, these are three longitudinal bands of the colon that will lead you to the base of the appendix. In terms of blood supply, the appendix is supplied by the appendiceal artery, which arises from the ileocolic artery, which is also a branch of the superior mesenteric artery, or SMA. The mesoappendix is a folded peritoneum that contains the appendiceal artery, as well as associated lymphatic tissues. The position of the appendix can vary, but the most common location is rectocecal, seen in about 60% of patients. And then the other most common position of the appendix is by the pelvic region, which is 30%. In this image, you can see a really nice illustration of all the anatomy near the appendix. One anatomical landmark that I want to give special attention to is the ileocecal fold, which is a peritoneal connection between the ileum and the cecum. From a surgical standpoint, it serves as an important anatomical landmark and oftentimes is used as a surgical window when performing an appendectomy. Let's continue by discussing the surrounding anatomy to the appendix. The appendix lies in close proximity to several key retroperitoneal and pelvic structures that are important during diagnosis and surgical dissection. Posteriorly, it's adjacent to the psoas major muscle, which is clinically relevant in retrocecal appendicitis and psoas sign. Nearby retroperitoneal structures include gonadal vessels and ureter, which both can be damaged if not handled carefully. In the pelvis, a lie-lowing appendix may be adjacent to the urinary bladder, and in females, the right ovary and fallopian tube. We also must consider the major vascular structures that are near the appendix, which are the common iliac and external iliac vessels on the right side. All of these anatomical structures we need to be aware of when performing an appendectomy. Now we're finally ready to discuss the pathophysiology of appendicitis. Acute appendicitis most commonly begins with luminal obstruction, most often due to lymphoid hyperplasia, followed by fecalis, also known as appendicolith, which is just a fancy way of just saying a poop stone. Other forms of obstruction can be caused by neoplasms or parasitic infections, but these are less common. With obstruction, this leads to increased intraluminal pressure, which results in venous congestion, bacterial overgrowth, and eventually gas accumulation within the appendix. This can progress to ischemia and transmural inflammation, which can ultimately result in gangrene with or without perforation if untreated. These infections are typically polymicrobial, but most commonly involves gram-negative enteric organisms, including E. coli, Klebsiella, and Pseudomonas. I won't go into great detail, but here are some differential diagnoses that can also present similarly to appendicitis. Let's go ahead and move on to the physical exam portion. If there's a clinical case that makes us suspicious of appendicitis, there are several exam maneuvers that can help support the diagnosis of acute appendicitis. The first one I want to cover is called McBurney's point. McBurney's point tenderness is the most classic finding, and it's located 1/3 of the distance from the anterior superior iliac spine to the umbilicus. The next sign I want to cover is called psoas sign. It is positive when hip extension or passive extension of the right thigh elicits pain. This suggests irritation of the psoas muscle, typically seen in a retrocecal appendix. The obturator sign is elicited by flexing the right hip and internally rotating the thigh, causing pain from irritation of the obturator internus muscle. And finally, the last sign I want to go over is called Rovsing sign, and this presents with palpation of the left lower quadrant, causing pain in the right lower quadrant. All of these different maneuvers can help us identify whether or not this patient has appendicitis or not. Even though the patient might present with right lower quadrant pain, a physical examination isn't good enough to make a final diagnosis. Let's go over the initial management of a patient that has right lower quadrant pain. The initial management begins with a thorough history and focused physical exam, again using those maneuvers that we just covered, followed by early supportive care. We need to establish peripheral IV access, obtain basic labs, and begin fluid resuscitation if the patient is hemodynamically unstable. A urine analysis should be obtained to help rule out things such as pyelonephritis or nephrolithiasis, and all females with reproductive potential should undergo a beta HCG to exclude ectopic pregnancy. The patient should be kept NPO and started on supportive therapy, including analgesias, antiemetics, and IV fluids as needed. Lucky for us, we have different risk stratification scores that can help us deduce if this is appendicitis or not. The most common one being Alvarado score, which helps guides the need to further workup and imaging. And finally, definitive evaluation is typically completed with imaging studies, most commonly ultrasound or CT, depending on the patient. Let's go ahead and dive in a little bit more deeper in what Alvarado score is. The Alvarado score is a clinical decision tool used to assess the likelihood of acute appendicitis based on history, physical exam, and basic lab findings. It's a 10-point scoring system. You can remember the components of the Alvarado score by using the mnemonic MANTRALS. This includes migration of pain, anorexia, nausea or vomiting, tenderness in the right lower quadrant, rebound tenderness, elevated temperature, leukocytosis, and shift to the left. Now, for interpretation. A score that is 1 to 4 suggests low probability of appendicitis. These patients may be observed or discharged with follow-up. A score 5 to 6 is equivocal and typically warrants further evaluation with imaging. And then 7 to 10 indicates high probability of appendicitis and usually prompts surgical consultation and management. Just remember, Alvarado score is a risk stratification tool, not a definitive diagnostic test. It should always be used in conjunction with clinical judgment and imaging when appropriate. Now let's talk about imaging. Imaging plays a key role in confirming appendicitis. Abdominal x-ray is not diagnostic for appendicitis, but it may be used in the emergency department to detect pneumoperitoneum, which suggests a perforated viscus. CT abdomen with IV contrast is considered the golden standard for adults. It provides high diagnostic accuracy and can also identify complications. Supportive findings include periappendiceal fat stranding, presence of an appendicolith, appendiceal wall thickening greater than 3 millimeters, and a distended appendix with a diameter greater than 6 millimeters. Ultrasound is the preferred initial imaging modality in children and pregnant patients to avoid radiation exposure. Similar findings include appendiceal wall thickening greater than 3 millimeters and a non-compressible dilated appendix greater than 6 millimeters in diameter. Once we have the diagnosis of appendicitis, we need to classify it. There are two main groups of classification. We have uncomplicated appendicitis and complicated appendicitis. Uncomplicated appendicitis refers to inflammation without evidence of perforation or abscess, and management options include early appendectomy or, in selected cases, antibiotic therapy alone. Complicated appendicitis includes perforation and abscess formation. A perforated appendix is a surgical emergency and requires urgent appendectomy combined with broad-spectrum antibiotics due to risk of generalized peritoneal contamination. In cases with an appendiceal abscess, if the patient is hemodynamically stable, initial management involves percutaneous drainage plus antibiotics. Surgically is typically delayed, allowing inflammation and infection to subside before proceeding with an appendectomy. Now the question is to operate or not to operate. Can we treat this infection with antibiotics alone, or do we have to undergo surgery? Well, that question was addressed in a recent study called the CODA trial, performed in 2020. It was a large randomized study comparing antibiotic therapy versus an appendectomy with patients that had uncomplicated appendicitis. Patients were randomized into two groups, the appendectomy group versus a 10-day course of antibiotics group. At day 30, antibiotic therapy was found to be non-inferior to appendectomies, supporting that antibiotics are an acceptable initial management strategy in selected patients. However, long-term follow-up showed important limitations. As you can see, by day 90, approximately 29% of patients in the antibiotic group ultimately required an appendectomy. Patients with an appendicolith had significantly higher fail rates, with nearly 49% eventually undergoing surgery. So overall, the trial supports antibiotics as a reasonable initial option in uncomplicated appendicitis, but it also highlights a lot of risks of later surgical intervention, especially with those that have an appendicolith. I also think it's worth mentioning how to address appendicitis in special populations, particularly in pregnant patients. Appendicitis during pregnancy is a serious surgical condition, as delays are associated with significant maternal and fetal risk. In cases of complicated appendicitis, the risk of preterm labor can be as high as 11%, and fetal loss may occur in approximately 6% of cases. Because of these risks, early intervention is critical to prevent progression to perforation and peritonitis. When surgery is required, laparoscopic approach is generally preferred. as it has been associated with fewer adverse maternal and fetal outcomes compared to open surgery. Appendicitis isn't the only reason why a patient might undergo an appendectomy. Appendiceal tumors are another reason. The most common appendiceal neoplasm is carcinoid tumors, which accounts for about 65% of all appendiceal tumors. Management is size dependent. Tumors less than 1.5 centimeters are typically treated with appendectomy alone, while tumors greater than 1.5 centimeters generally require a right hemicolectomy due to increased risk of lymphatic spread. Other less common malignant tumors include adenocarcinoma and mucinous adenocarcinoma, which tend to have a more aggressive course and may present with peritoneal spread in advanced cases. The last point I want to touch on is the different surgical approaches to an appendectomy. Appendectomy can be performed via either a laparoscopic or open approach. The laparoscopic approach is now the standard of care and has become increasingly preferred. It's associated with less postoperative pain, fewer wound infections, and shorter hospital length of stay, along with faster recovery. The open approach is less commonly used today, but remains important in select cases, such as complicated anatomy or lack of laparoscopic resources. The traditional incision is the McBurney incision, exactly where we had that McBurney's point. McBurney's incision is an oblique muscle splitting incision that follows the fibers of the external oblique muscle. A modified alternative is Land's incision, which is a transverse incision placed along Langer lines, offering improved cosmetic outcomes compared to classic McBurney's approach. In this illustration, you can see the McBurney's incision follows the tract of the fibers of the external oblique muscle, whereas the Land's or modified McBurney's incision is more transverse, following the Langer lines. So in summary, appendicitis is a common but potentially serious surgical emergency, and timely intervention is required to prevent complications. In the description below, I'm going to attach a couple of videos from other YouTube channels that kind of show you the steps on how to perform an appendectomy. There will be a video for the open approach and the laparoscopic approach of an appendectomy. I hope you enjoyed this video and that was helpful for you in your studies, and best of luck to your surgical ventures.